Our first presenter. So Dr. Kirsten Oler is going to be presenting the section on pediatrics to you. So Dr. Oler received her Bachelor's of Science degree in pharmacy from Ohio Northern University and her PharmD degree from the University of Toledo. She completed a pharmacy practice residency at the University of Illinois at Chicago, and in 1998 a pediatric specialty residency at Children's Hospital in Columbus, Ohio. Afterwards, she focused her clinical practice primarily in neonatal intensive care unit, and most recently at the University of Illinois at Chicago, where she's also a clinical assistant professor in the Department of Pharmacy Practice. During her career, she has served as program director for her pediatric specialty residency at Children's Hospital, Columbus, Ohio, and has served as a faculty member for the American College of Clinical Pharmacy Updates and Therapeutics course since 2003. So Dr. Oler's research interests include neonatal and pediatric pharmacokinetics, antimicrobial stewardship, and bacterial resistance. So let's give a welcome to Dr. Oler, who's going to kick us off with pediatrics.
Thank you, Dr. Hemstreet, for that kind introduction. Although I wish you wouldn't have mentioned the years that I completed my things. It makes me feel a little older than I want to be. Anyway, welcome everybody to the prep course. In this session, we're going to take you on a fast journey through the age spectrum. We're going to start, as we all did, as children, and then we'll move on to the geriatric section. I'm pretty happy to say that in the past week or so, BPS has recognized PEDS as its own specialty. So hopefully in the next few years, we'll have a course like this dedicated just to PEDS. But for now, everything you need to know in pediatrics in 1 hour. We will be using on occasion your audience response cards, so if you have those handy, that'll be helpful. And to get this all in an hour, we're going to try to work through the cases in your chapter in the order that they appear there on neonatal and pediatric sepsis and meningitis, respiratory syncytial virus infection, otitis media, immunizations, pediatric seizure disorders, and attention deficit hyperactivity disorder, which it seems like maybe I have, covering all these topics in an hour. So, to do that, really what I'm going to try to do is focus on some of the key pharmacotherapeutic issues, try to focus on some of the things that you need to think about that are different in kids than adults, because a lot of the principles that you're all aware of in terms of clinical practice apply no matter what your patient population is. So we'll jump right into case number 1, which is that of a neonate who's born prematurely at 36 weeks gestation. He develops respiratory distress, hypotension, and mottling at 5 hours of life. He's admitted to the neonatal intensive care unit where he has a witnessed seizure. Relevant history is that the maternal vaginal cultures are positive for group B streptococcus, but mom did receive 3 doses of penicillin prior to giving birth. Cultures are drawn on admission, and the results are pending at this point, and we're asked what would be the best empiric antibiotic regimen to choose for this patient. So would we choose vancomycin? Would we choose ampicillin plus gentamicin, ampicillin plus ceftriaxone, or ceftazidime plus gentamicin? So, to answer this question, first we need to recognize that the signs and symptoms are consistent with sepsis. And in a pediatric patient, ruling out sepsis generally means ruling out meningitis as well. So that means when we're choosing our antibiotics, we need to pick something that's going to penetrate well into the cerebral spinal fluid, and we need to dose it in what we often refer to as meningitic doses, so often higher doses than we might use for other infections. We also, just like any other infectious disease, need to be aware of what the most common causative organisms are. And in pediatrics, this varies by age group. And as you can see, for our patient here, who is, I don't think I can even find the screen with this pointer, who is just 5 hours of life, falls into the first category, 0 to 1 month of age. And neonatal sepsis can then be further subdivided into early neonatal sepsis, which generally occurs within the first 72 hours of life. And in those cases, the pathogens are usually those associated with the maternal genitourinary tract. So we're talking about group B streptococcus, E. coli, listeria, perhaps viruses like herpes simplex virus. And then we can have late neonatal sepsis, which happens beyond 72 hours of life, often beyond the first week of life. And this can happen in otherwise healthy newborns. So they were born, they went home, they come back septic. Or it can happen in a neonate who's been hospitalized since birth. And so depending on what that patient population is, it depends on what organism we're looking at. So if it's late sepsis in an otherwise healthy newborn who had gone home and became septic, then we're still talking about mostly the pathogens associated with early sepsis, so group B strep, E. coli, listeria. If it's late neonatal sepsis in a patient who's been hospitalized since birth, we're still worried about those organisms, but we're also worried about nosocomial pathogens like coagulase-negative staphylococcus, some other gram-negatives like Enterobacter and Pseudomonas, and fungus, primarily Candida albicans. So back to our patient. So the presentation within 5 hours of life suggests to us early neonatal sepsis. And so vancomycin wouldn't be the best choice in this case because we're not worried about coagulase-negative staph. We also don't have any gram-negative coverage for E. coli, which we actually would be concerned about in this case. Ampicillin and ceftriaxone actually provides adequate coverage for the organisms we're worried about. But when we talk again about selecting drugs for pediatric and neonatal patients, we also have to think about side effects, and often those side effects differ in this population versus adults. So for example, for ceftriaxone, it's associated with biliary sludging, which can increase serum concentrations of bilirubin, which in a premature baby can, or any neonate, can cross the cerebrospinal into the cerebrospinal fluid, deposit in the brain, associated with a condition we call kernicterus, which has poor outcomes in terms of neurodevelopmental delays, cerebral palsy, those kind of things. So although the antibiotic spectrum of this combination might be appropriate, we wouldn't pick it because of the known side effects that could affect this patient population. Ceftazidime and gentamicin wouldn't really provide good coverage, especially not for group B streptococcus. Also, empiric double coverage of gram-negatives in early neonatal sepsis is not indicated. So the best option we have from this list is ampicillin and gentamicin. Remembering that we would give these in meningitic type doses, and also that in neonates and other children, you expect differences in pharmacokinetics compared to the adult population. So for example, aminoglycosides have a much larger volume of distribution in this patient population and generally a much slower clearance. So we may be giving gentamicin in this case on a higher milligram per kilogram per dose basis at longer intervals than you would traditionally see in older children or adult traditional dosing. Some of you might think, well, what about ampicillin and cefotaxime? I've seen that used in this situation. And again, that's appropriate coverage. It's not generally the first-line combination that we use because there is concern about resistance to the third-generation cephalosporins. There's also some evidence that neonates treated with this combination compared to ampicillin and gentamicin have poorer outcomes and a higher mortality. So in general, ampicillin and gentamicin are the combination antibiotics of choice for empiric treatment of neonatal sepsis. Case 2 is a continuation of the same patient. We now have culture results back, and we see that there are gram-negative rods in the cerebrospinal fluid. And the team asks us, what should we do about antibiotic prophylaxis in this case? Who needs antibiotic prophylaxis? Should we give it to the 5-month-old stepsister who, because she's not fully immunized yet at this age, would presumably also be at high risk for sepsis? Should the patient receive rifampin to eliminate nasal carriage of the pathogen? Is antibiotic prophylaxis even indicated in this case, or should we be giving it to everybody? So to answer this question, we really need to know what is the purpose of giving chemoprophylaxis in the case of bacterial meningitis. And the primary purpose is to prevent the spread of Haemophilus influenza as well as Neisseria meningitidis. And there's a very targeted high-risk groups that, regardless of their immunization status, would require prophylaxis. And it's important to know this because sometimes when these cases come up in practice, it gets pretty willy-nilly. Everybody wants to have prophylaxis. So the targeted groups are those household contacts, people that live in the house with the index case. Nursery school and child care attendants contacts, and those in direct contact with the patient's respiratory secretions. So this is where we get a lot of questions. I've been before on a code of a patient who had Neisseria meningitidis sepsis, and the entire peds ICU thought they needed, prophylaxis because of it. Me as the pharmacist standing at the code cart, drawing up the meds, not in contact with the patient, I don't need prophylaxis. The nurse taking care of the patient across the unit, not involved in the care of this patient, doesn't need prophylaxis. So it's important that we're not overusing prophylaxis. As with any antibiotic, we worry about resistance developing. But if we do choose to prophylax, the drug of choice is rifampin. So if we go back to our case, based on what we know to be now the most likely organisms for this particular patient, it's most likely that his gram-negative rods are E. coli or Klebsiella, right? So we're not really worried about the gram-negatives that we would provide chemoprophylaxis for. So in this case, prophylaxis is not indicated. If the patient were older and we were concerned about Neisseria or Haemophilus influenza, then certainly any of his close contacts should receive prophylaxis, regardless of their immunization status. So speaking of older patients, case 3 is that of a 6-year-old boy who presents to the emergency department with a fever and altered mental status. Thanks, Dr. Hemstreet. Altered mental status and petechiae. There's no history of trauma related to this event. Because of the altered mental status, a toxicology screen is performed, but the results are negative. Patient has an elevated white blood cell count at 32,000 with a left shift on the differential. And so cultures are drawn and the results are pending. The patient is not known to have any drug allergies, so we're asked what again is the most appropriate empiric antibiotic regimen for this patient. We have again ampicillin and gentamicin, cefuroxime, ceftriaxone and vancomycin, or rifampin. So as with before, it's important to identify which age group our patient falls into. And you can see at 6 years of age, this patient falls into the biggest category of those patients between 3 months and 12 years. And here's where we're worried about Haemophilus influenza, Neisseria meningitidis, and Streptococcus pneumoniae. Now I'll say that Haemophilus is much less common now because of widespread use of vaccines, but in my institution and in others, we are seeing a resurgence of cases of Haemophilus, sepsis, and meningitis because of parents choosing not to vaccinate their children. And we'll talk a little more about that later in the presentation. So here we have a 6-year-old. We're worried about Haemophilus influenza, Neisseria meningitidis, Streptococcus pneumoniae. So from our choices, this time ampicillin and gentamicin is not a good choice. It's not going to cover our most common pathogens. Cefuroxime, although perhaps will cover what we're worried about, does not penetrate the cerebrospinal fluid well. And remember, we said rule out sepsis equals rule out meningitis, especially in a patient like this who presents with altered mental status. You're worried about meningitis in a case like this. Rifampin, as we mentioned, is the drug of choice for prophylaxis, but not recommended for treatment, especially not alone. So in this case, ceftriaxone would provide safe coverage in an older patient. We're not worried about the biliary sludging. It would cover the organisms we're worried about. The addition of vancomycin depends somewhat on your regional susceptibility patterns. So if you practice in an area where there's not a high incidence of cephalosporin-resistant Streptococcus pneumoniae, perhaps you don't empirically use vancomycin. Where I practice, the resistance rates are very high, so vancomycin is always in our regimen. Obviously, as with any other infectious disease, once we know the identification and susceptibility of the organism, then we would tailor our drug therapy accordingly. All right, now we're going to shift gears a little bit to respiratory syncytial virus infection with case 4. Here, you're screening babies during RSV season for risk factors associated with severe RSV infection. And you're asked, which of the following is the best recommendation regarding the use of palivizumab for prophylaxis? So we have patients that we're trying to decide, should we or should we not give them palivizumab for prophylaxis? The first one is born at 34 weeks gestation, so is premature, and has a congenital heart defect. The second one is 21-day-old infant who is also born prematurely at 31 weeks gestation, is an only child, doesn't go to daycare, parents don't smoke. Patient C, also born prematurely, is now 5 months old, has a history of chronic lung disease, or for you old-timers, bronchopulmonary dysplasia, that's what I still remember it as, but is not receiving oxygen or any medications for this indication. And then patient D is 18 months old, also born prematurely at 26 weeks gestation, also has a history of chronic lung disease, but not been treated in the last 8 months for that. So what's important to think about when we're trying to answer this question is, one, what is palivizumab? Well, it's a monoclonal antibody that's been indicated for the prevention of hospitalizations due to severe RSV infection. And severe RSV infection happens in a fairly targeted high-risk population. And we worry most because there's a significant mortality associated with it. We give palivizumab on a monthly basis during what we usually refer to as RSV season, and that time frame depends on your geographic location. So, for example, where I practice in the Midwest, our season usually runs somewhere between late October, early November, peaks in about January, February-ish, and then ends in late March, early April usually. So, depending on where you practice, that might be a little earlier or later in the year. So what are the risk factors for severe RSV infection? The number one risk factor is premature birth. Chronic lung disease, or BPD, is also a risk factor, as is congenital heart defects. Immunodeficiency states and airway abnormalities that preclude the patient from appropriately handling their respiratory secretions can also put them at risk for severe RSV infection. Some secondary risk factors include low socioeconomic status, passive exposure to cigarette smoke, daycare attendance, and young siblings in the home. So based on these risk factors, the American Academy of Pediatrics developed guidelines based on which children would benefit most from receiving palivizumab prophylaxis against RSV infection. And as you can see from this table, basically, anybody born prematurely, less than 32 weeks gestation, is an eligible candidate for RSV prophylaxis with palivizumab. They don't need any other risk factors if they're born less than 32 weeks gestation. If they're born prematurely, but between the 32 and 34 weeks plus 6 days gestation, then that's the category that needs an additional risk factor to truly benefit from RSV prophylaxis. And the risk factors that the AAP has identified are either daycare attendance or siblings less than 5 years of age within the household. Now, we kind of use that risk factor loosely. Where I practice, we have a number of families that their extended family lives with them or those kind of things. So any child less than 5 years old, they don't have to be a blood sibling, we count as a risk factor. There are some risk factors that are regardless of the patient's gestational age. So any child less than 2 years of age who has a congenital heart defect would qualify for palivizumab prophylaxis. Any child less than 2 years of age who has chronic lung disease, which has been treated within the past 6 months, and by treated I mean either received oxygen therapy, diuretics, or bronchodilators, then those patients qualify for palivizumab prophylaxis. Or any patient less than a year of age who has congenital abnormalities of their airway or neuromuscular diseases that impair their handling of respiratory secretions would also be appropriate candidates. So with those recommendations in mind, we go back to these patients and say, who should we not give palivizumab to? Patient A has a cyanotic congenital heart defect, so qualifies regardless of gestational age. So until the defect is fully repaired, would be at high risk for mortality associated with severe RSV infection. Patient B, born prematurely, less than 32 weeks, so would be an eligible candidate, does not need to have any other risk factors except for prematurity. Now, if this patient were 33 weeks gestation, then the fact that they're an only child, that they don't go to daycare, would make the use of palivizumab not cost beneficial in that patient. Patient C, again, born at 29 weeks, is less than 6 months of age, so again would be an eligible candidate, even though their chronic lung disease has not been actively treated lately. So that leaves patient D as the patient that it would be least cost beneficial to use palivizumab prophylaxis in. This patient has chronic lung disease, was born prematurely, but is older and has not received any medical management of their chronic lung disease in the past 6 to 8 months. So they would benefit the least, so that would be the correct answer here. So case 5 is that 18-month-old patient who was born prematurely with chronic lung disease, who is admitted to the pediatric intensive care unit with respiratory distress, requires intubation, has a fever, and had a 3-day history of cold-like symptoms. The nasal swab is positive for respiratory syncytial virus. So although this patient isn't necessarily one that we would think of as high risk for RSV, it does not mean that they can't get RSV. Any number of patients can get an RSV infection, but the likelihood of a severe infection are in those other risk factor categories. So here's where we'll use the response cards for the first time. We're asked, what is the best intervention to make for the treatment of this patient? So we have palivizumab, corticosteroids, cefuroxime, or intravenous fluids and supportive care. So what do you think? All right, good. I see a lot of yellow. Good. So palivizumab, while it is the drug of choice for prophylaxis, does not have a role in treating RSV-positive patients. The other question that comes up a lot in clinical practice about palivizumab is, should we give it when we have a patient with an active RSV infection in our unit? Should we give it to other high-risk patients to prevent the spread of RSV within our unit? And the American Academy of Pediatrics says no. They say that good hand hygiene and isolation of the index case is the way to prevent nosocomial outbreaks, that we shouldn't be using palivizumab. It's not effective in that role. Corticosteroids have not been proven to decrease the length of stay or mortality associated with RSV infections, so they're not routinely recommended. Cefuroxime, you hear a lot about secondary bacterial infections with RSV, but in reality, the incidence is less than 2%. So the use of empiric antibiotics in this case is not indicated either. So supportive care is our primary option. Some of you might be familiar with ribavirin, an antiviral that we have used in the past to treat RSV. The American Academy of Pediatrics, in their recommendation, says it may be used for severe cases, for example, patients with congenital heart defects or chronic lung disease who are not responding to supportive care. However, I would say in clinical practice it's very, very rarely used, if at all. Case 6 moves us into otitis media. So we have a 5-month-old infant who's born at term, who's otherwise healthy, who was recently treated for her first case of otitis media with amoxicillin 45 milligrams per kilogram per day for 7 days. She's back at pediatric clinic for follow-up, and the physician notices she still has fullness of her middle ear and her tympanic membrane is somewhat cloudy, but she's afebrile, and her mother says that she's been eating very well. So we're asked, what is the best treatment recommendation to make at this time for the patient? Are no further antibiotics warranted? Should we treat her with high-dose amoxicillin? Should we recommend decongestants and antihistamines? Or should we switch to azithromycin? So again, we need to know what our most common pathogens are. And in otitis media, viral organisms are the most likely cause, followed by Streptococcus pneumoniae, non-typable Haemophilus influenza, Moraxella catarrhalis. But unlike most other infectious diseases, we're not going to have a culture to prove any of this. Blood cultures aren't helpful. We don't routinely do tympanocentesis to get inner ear fluid. So we're basing our treatment on these most likely causative organisms. Regardless of the organism, there is a high clinical resolution rate. About 70% of cases will be self-resolving without any antibiotic therapy. So in the case of a patient who has a bulging tympanic membrane or a perforated tympanic membrane, immediate antibiotics are warranted, but because of that high resolution rate, if there's not severe signs or signs of severe systemic infection, if the tympanic membrane is not bulging or perforated, and if the child is older than 2, then we can adopt what the AAP recommends as watchful waiting. So that means we don't initiate therapy unless the otalgia, the ear pain, and the fever persist for more than 48 to 72 hours. And again, that's because there's such a high spontaneous resolution rate and because viruses are the most likely cause. We can also adopt this approach in younger patients, those between 6 months of age and 2 years of age. We might defer antibiotics if the symptoms are mild and if we're not quite certain if it's an otitis media or not. When doing this in clinical practice, you have to assess the parent's ability to, 1, recognize severe symptoms, and 2, initiate therapy if need be. For patients like ours, in this case, that have a persistence of middle ear fluid, but no systemic signs, that's termed otitis media with effusion, and generally antibiotics are not warranted in that case. So, as I mentioned, in this case, antibiotics are not warranted. But if this patient were diagnosed with acute otitis media, so if she still had systemic symptoms, the drug of choice would still be amoxicillin. We would give her high-dose amoxicillin, which is the recommended regimen. Lower doses are not recommended, so even if she failed that lower dose amoxicillin, it wouldn't be an indication to change drugs. It just would be an indication to give a more appropriate dosing regimen. Decongestants and antihistamines have not been shown to improve clinical resolution or improve symptoms associated with otitis media, so they're not recommended in children. Azithromycin, which we see all the time, is not a good choice for otitis media. A significant number of strains of Streptococcus pneumoniae, I've seen reports over 70% are resistant to azithromycin. It also has poor activity against Haemophilus, so although convenient, not a good choice for these patients. All right, and then case 7, we'll look at a 4-year-old boy who is diagnosed with his 4th case of otitis media in a 12-month period of time. He has no evidence of hearing loss or delayed language skills associated with his otitis media, and we're asked what is the best intervention to make at this time. So let's see what your responses are. Again, we'll use the audience response cards. Do you think we should recommend long-term prophylaxis, recommend tympanostomy tubes, recommend high-dose amoxicillin and vaccinations, or that no antibiotics are warranted? Don't cheat and look at the back of the answers. What do you think? Good, we have a lot of choices. So I see almost every color in the rainbow out there. So in this case, we used to prescribe long-term antibiotic prophylaxis. But it's been found that that really doesn't significantly reduce the number of otitis media cases, maybe reduces them by about 1 case per year. And because of the concerns over resistance and the marginal beneficial effect, we don't recommend that in clinical practice any longer. Tympanostomy tubes typically are recommended for those patients who fail aggressive therapy and who have associated hearing loss and language delays because of the otitis media. So those are the patients that respond best to that intervention. Watchful waiting, although our patient is older than 2 years of age, watchful waiting and delaying antibiotic therapy is not recommended for recurrent otitis media, which is what this patient has. So recurrent otitis media is 3 or more cases of otitis in 6 months or 4 cases in a year. So the best answer here is still to continue with high dose amoxicillin. As long as our patient responds and resolves with each case, then amoxicillin is still the drug of choice. Obviously, vaccines are important because some of the viruses and Streptococcus pneumoniae are causes of otitis, and hopefully we can prevent those with vaccines. If the patient doesn't respond to high-dose amoxicillin, then that's the time that we would choose an alternative therapy, or that's the time where we might see tympanocentesis done to actually culture the inner ear fluid. All right, finally we'll wrap up our tour through common pediatric infectious diseases with some cases on immunizations. I could spend the entire hour and more talking about immunizations. It's something I'm very passionate about, and I think as pharmacists we should be champions for. But today we're not going to spend the whole hour on it. I'm going to try to highlight some of the important things that we should know. So in case 8, we have a 1-year-old boy who has a history of Kawasaki's disease who received treatment with intravenous immune globulin 4 months ago. He's at a well child visit now where it's found that he's due for the measles, mumps, rubella vaccine as well as varicella vaccine. He has no known drug allergies, but he has multiple food allergies, including peanuts, eggs, and shellfish. And mom has several concerns about immunizing him at this point. So we're asking this question, what is the best reason to defer immunizations in a patient like this? Is it mom's concern over an association with the MMR vaccine and autism? Is it a concern over an allergic reaction with MMR and an egg allergy? Is it the concern that many concurrent vaccines can overload the immune system? Or is it a concern that there may be decreased efficacy of the vaccines due to a previous IVIG exposure? So what we're going to talk about related to vaccines today is really the myths and misconceptions that lead to missed opportunities for immunization. It's very important as pharmacists that we understand what's a true contraindication and what isn't. And you'll see from this list there's very few true contraindications to giving immunizations. So among those are an anaphylactic reaction to the vaccine or one of its components, an acute moderate to severe febrile illness, immunodeficiency, pregnancy, or recent IVIG exposure in a patient who's due for live vaccines, or a history of encephalopathy within 7 days of a previous DTaP vaccine. That's it. Those are the only true contraindications to vaccines. Things that many people misconceive as contraindications are any kind of acute febrile illness, any kind of fever. It's not an absolute contraindication, only if the patient's having severe systemic symptoms of infection. Current antibiotic use does not preclude us from vaccinating. Having a pregnancy in the household is another reason why it often is stated to defer immunizations. And again, that's just not true. That's not a contraindication to immunizing a child. And then, of course, this concern over autism. And this is something that I think as pharmacists we also need to be very familiar with the data on, because I get asked on multiple occasions about this. It's a large concern for parents. There's a lot of misinformation in the internet, on TV, voiced by celebrities and everybody else. So what's important to know is the journal Lancet in 2010 actually retracted the study that led to this concern because it was found that the investigator falsified their data. So this concern about associations with autism and MMR were totally based on falsified data. Just last month, the CDC published another study, a very large study, more than 1,000 children, that showed that there was no association between autism and multiple vaccine products. So as pharmacists, I, at least in my practice, get asked this a lot, and I think it's important to be aware of the issues and the parents' concerns so that we can appropriately educate them and address those concerns. The other thing we need to know about is what the AAP terms these special populations. So there's some patient populations where there's additional considerations when we're thinking about should we vaccinate or not. And in the case of our patient who's recently received IVIG, it's that it can affect the immune response to live vaccines, so things like MMR and varicella. It does not affect the immune response to inactivated vaccines, so it's important to know what the patient's due for and also what the timing of the IVIG was. I would here refer you to what's called the Red Book. It's an American Academy of Pediatrics publication on infectious diseases. Has a very comprehensive chapter on immunizations. The recommendations related to IVIG are extensive depending on what the indication for IVIG is as well as what the dose of the IVIG was. But suffice it to say that if a patient is getting a live vaccine and has had IVIG, it warrants you investigating should you delay or not. In the NICU, where I most commonly practice, we're giving inactivated vaccines, so it does not delay my vaccination of my patients in that population. So back to this case. The most appropriate reason for this patient to defer vaccines is, again, the potential for decreased vaccine efficacy because of his recent IVIG administration. Although MMR is grown in chick embryo tissue, there's no evidence that it causes a severe reaction in those who have an egg allergy, so it's not a contraindication. This concern about concurrent vaccines and their overload on the immune system is a real one. I hear that from patients as well as some healthcare workers. That's also something that's proven not to be true. A child's exposure to multiple antigens in their lifetime is probably much more significant than what they get from the small doses from vaccines. So that actually is not true, but something that comes up fairly often. Case 9 is a case of multiple children who have come to pediatrics clinic and are due for vaccines based on the routine schedule. And again, we're asked who would be best to, who would it be most appropriate to defer immunizations in? So patient A is a 12-month-old boy who's recently completed chemotherapy for a cycle of chemotherapy for ALL. Patient B is a 6-month-old girl who's on amoxicillin for otitis media. Patient C is a 12-month-old boy with HIV who has adequate CD4 counts. And patient D is a 12-year-old girl who's completing a prednisone burst of 1 milligram per kilogram for an asthma exacerbation. So this is very busy. This is the most recent immunization schedule, and I put it up here just to give you an idea of how complex it is. It changes every single year. I don't have it fully memorized myself. I've been doing this for a long time, and it's just too much in my brain. So I know where to look it up. I know how to interpret the table. I know the important things that I'm looking for on the table, and that's what I would suggest is important for you guys as well. So if we look at this table, the columns are different ages. And so if we look at 6 months of age, we see, which is one of our patients in consideration, we see that that patient would be due for a hepatitis B vaccine, a DTaP, a Haemophilus influenza, and a pneumococcal conjugate vaccine. All of these are inactivated products, so that's important to think about. If we look at 12 months of age, which another of our patients was, we see that that patient is due for measles, mumps, and rubella, as well as varicella and other boosters. And at 12 years, our patient would be due for human papillomavirus vaccine, HPV, meningococcal, as well as Tdap, again, inactive vaccines. So if we consider our special populations again, here we have an immunocompromised patient because they just completed chemotherapy, so the recommendation is we don't give live vaccines, but we could give inactivated vaccines. Patients on corticosteroids, the recommendations depend on the dose of the steroid as well as the duration. So if the dose has been less than 2 milligrams per kilogram per day, or if the dose is higher than that but for less than 14 days duration, then it's okay to go ahead and give live vaccines. Again, this is only related to live vaccines, not inactive products. If the dose of corticosteroids has been more than 2 milligrams per kilogram per dose and more than 14 days, then the recommendation is to delay for at least 1 month after completion of the steroids for live vaccines. And then in HIV-infected patients, the recommendations depend on their immune status. If the patient's asymptomatic and has an adequate CD4 count, then the recommendation is to give all age-appropriate vaccines, even live vaccines. So based on that, we would choose patient A as the most appropriate in which to defer because he is immunocompromised, and at 12 months of age he is due for live vaccines. MMR and varicella are the live vaccines that we're worried about here. All right, so that's all for the infectious disease component, and now we're going to move on to pediatric seizure disorders. So case 10 is a 14-year-old moderately obese girl who complains of an erythematous pruritic rash. She was recently started 3 weeks ago on oxcarbazepine for her partial or focal seizures. She admits to being sexually active with a male partner, and she's also admits to being pretty inconsistent in her contraceptive use. So we're asked what should be the best intervention to make for this patient. Should we change her medication to carbamazepine, change to levetiracetam, change to valproic acid, or is no change indicated at this point? So as we're considering that question, it's important to note that just like seizures in adults, pediatric seizures, there are certain drugs that are indicated for different seizure types. So in this patient with partial or focal seizures, we see that valproic acid and carbamazepine are among the drugs of choice, but there are a lot of alternatives, including oxcarbazepine, levetiracetam. So when we're trying to choose, a lot of our decisions go into what the side effects are, what the pharmacokinetics are, what the patient's history is, those kind of things. So when we're trying to decide should we change this patient's drug therapy, we also need to assess, is her complaint really related to side effects of the drug or not? And the side effect profile for a lot of these anti-epileptic drugs can be different in children than adults. And as well can the pharmacokinetic profiles of these drugs be very different in children than in adults. And I kind of spell that out in the table 7 in your chapter. This slide is just a summary of the most common side effects taken from that table, since that's what we're concerned about with this question. And you can see that rash is a pretty common side effect associated with anti-epileptic drugs, including oxcarbazepine. Carbamazepine, which was one of our alternatives, is also associated with rash. It actually has a higher incidence than does oxcarbazepine, and there's a fairly significant cross-sensitivity with about 30% of patients having a cross-sensitivity reaction. Valproic acid does not is not usually associated with rash, but it has some other undesirable side effects like weight gain, menstrual irregularities. It's a teratogen. It's pregnancy category D. So those are important things to think about. Levetiracetam, also not associated with significant rash, and it's a pregnancy category C drug. So if we think about this patient and our options, because she has a rash, and rashes are common with anti-epileptic drugs, and it's very difficult to determine if that rash is going to progress to something more severe like Stevens-Johnson syndrome, which it could, that means that we really should address that, and there is an indication for changing her therapy. Now, what do we choose? Carbamazepine, we said, was an appropriate choice based on her seizure type. However, we saw that it has a higher incidence of rash, so that's not the best option. Levetiracetam and valproic acid do not have a high incidence of rash, and both of them are appropriate for her seizure type. So then the question is, how do we pick between those two? And again, I think it comes down to side effect profile in this patient. So although valproic acid is listed as a drug of choice for her seizure type, if we think about a teenage girl and a drug that's going to cause weight gain and a drug that's going to cause menstrual irregularities, those kind of things are reasons why teenagers are not compliant with drug therapy. If you have a patient who's sexually active and not very good about her contraceptive, you're probably not going to want to prescribe a category D teratogenic drug to that patient. So from the options we have here, I would say that levetiracetam is the best option that we're given. All right, and then we're going to wrap up with 2 cases on attention deficit hyperactivity disorder. I always add a little disclaimer here before we get into the cases. I know that there's a lot of interest and controversy surrounding the diagnosis and the use of drugs in these patients. What we're going to do here is focus on the medical therapy, assuming appropriate diagnosis of these patients. So our patients have ADHD and do warrant medical therapy. So in the case of this 9-year-old boy who's newly diagnosed with attention deficit hyperactivity disorder and is having symptoms that are disruptive both at school and at home, we're asked what would be the best initial regimen for this patient. So our options are methylphenidate OROS, which I'm going to add in the brand names here because it's hard to differentiate this methylphenidate versus that one. So this one's Concerta. Methylphenidate immediate release is Ritalin, guanfacine, and then D-methylphenidate is Focalin. So when we're trying to decide what drug therapies to use, it's important to know that there's 2 really major categories that we can choose from. There's the stimulants and the non-stimulants. The stimulant agents are considered drug of choice for the treatment of ADHD. And then they're further subdivided into those agents that contain methylphenidate and those that contain amphetamines. So again, there's a much larger table, number 8 in your chapter. This is just a summary of what you'll find there. The methylphenidate products can be further categorized based on their duration of effect. So there's short-acting, intermediate-acting, and long-acting agents. The side effect profile, regardless of the duration of action, is fairly similar. And those side effects can be fairly troubling. They include insomnia, loss of appetite, headaches. They can exacerbate tic disorders, which is important in this patient population because depending on which reference you read, these patients between 20 to 90% can have a comorbid tic disorder. So having a drug that would exacerbate that might be very problematic. Amphetamine-containing stimulants also can be subdivided by their duration of effect. Adderall is a more intermediate acting versus Adderall extended release is more long acting. Again, the side effects are fairly similar to the methylphenidate containing products, but there is this additional warning about a potential association with sudden cardiac death. In 2005, the FDA added a warning to the use of Adderall recommending that it should not be used in patients with structural heart defects. And the reason for that was based on monitoring ADR reports, it was found that 5 out of the 12 deaths associated that occurred in patients with on Adderall, 5 out of 12 of those deaths occurred in patients with structural heart disease. So although there's no established causal relationship, the FDA was very cautious in their recommendation, saying that, we shouldn't use this drug category in those patients. So how do we do that in practice? Well, the AAP came out with some recommendations, and they said, really, before starting Adderall, you do a targeted cardiac history. Routine EKGs are not necessary unless there's something in the patient's history or physical exam that points to a likelihood of a cardiac disease. So Adderall in the United States is still available for use, and just with those cautions. It's important to recognize again, so stimulants are the drug of choice. And failure or an undesired response to one agent in the stimulant class does not predict failure to other drugs in the stimulant class. So we don't tend to switch from stimulants until we've tried at least 2 agents and seen failure. Because upwards of 80% of all children will respond to one stimulant or another. So if they fail to respond to at least 2 stimulants, then we start thinking about the non-stimulant agents. And again, there's a table 9 in the chapter that this slide summarizes. The most common non-stimulants that we use are Strattera, which is atomoxetine. It has the potential association of severe liver disease. And more recently, there's been a black box warning related to a potential increased risk in suicide in children and adolescents on this drug. So that's an important consideration. The benefit of the drug is that it does not exacerbate tics. So if we have a patient that has a severe tic disorder, that might be an important consideration. Clonidine is thought to be more effective in treating the hyperactivity symptoms of ADHD versus inattention. It can also lessen the severity of tics. Unlike the stimulant products which cause insomnia, clonidine can cause sedation. So if you're having some trouble with insomnia, clonidine might be an option. Guanfacine also can cause sedation, not to the same degree that clonidine does. And now with the newer extended release product, it has a longer duration of effect than does clonidine. But those drugs, as I mentioned, we usually reserve until we failed stimulants, or if we have patients with severe tics, then we might go to the non-stimulant products. So back to our patient, our 9-year-old boy. As I mentioned, stimulants are the drug of choice. He's having symptoms at school and at home. So that suggests that he's going to need a longer acting agent than one of the more immediate release type things. So methylphenidate IR, dexmethylphenidate are both short acting, and so probably not the best option on a 2-dose per day regimen for this patient. Additionally, dexmethylphenidate is really not a good drug to choose for anybody. The premise is that it's the D-isomer, so potentially has less side effects. That clinically has not been shown to be true, and is a lot more expensive than Ritalin or methylphenidate IR. So it's really not a very cost-beneficial agent in any patient population. Guanfacine, as I mentioned, one of the non-stimulants, usually we would reserve for patients that fail the stimulant agents. So in this case, a longer-acting methylphenidate product like methylphenidate OROS is a good choice. It has the added benefit, because it's long-acting, has the added benefit that we don't have to redose during the school day, which is an important consideration when we're choosing drugs for children, whether it be for ADHD or any other disease state. If we can make it simple for the family and the school and not have to dose during school hours, that's good. It's also important from a compliance standpoint. Having any disease state in a child or having to take medications makes them different than their friends. And being different from their friends makes them not want to do what it is that makes them different from their friends. And so from a compliance standpoint, things that add an additional stigma, things that make a child different from their friends, is something that we deal with more than perhaps the adult population. All old people are on medicines. Sorry, Jennifer, but it's true. And so that doesn't make them as different. So, but that's an important consideration when we're picking a drug. All right, so we'll wrap up and have a few minutes left for questions. With the same patient, so we started the longer-acting methylphenidate product. His symptoms have been well controlled, both at home and at school, but now he comes back complaining of insomnia. So the question is, what intervention should we use to help with the insomnia? So let's see what you guys think. Should we give Concerta later in the day, change to methylphenidate modified release, change to the methylphenidate patch, or change to atomoxetine at this point? What do you think? All right. We have some reluctance to answer. Well, you're right. It is more complicated than this. And that's why an hour to teach peds is difficult. So I'm trying to bring up some of the important concepts. So in this case, I saw some green, I saw some red. So to think about this, Concerta, so if we gave it later in the day, that would probably worsen the insomnia, right? But if our option was to give it earlier in the day, that might be a good option, because then that would allow blood concentrations to fall before bedtime, potentially decrease their risk of insomnia that way. Methylphenidate modified release might be a decent option. It's shorter acting than Concerta, so our concern would be then we would compromise his symptom control, which was very significant and disruptive both at school and at home. So that may not be the best option. Changing to atomoxetine. So we talked about that didn't have the side effect of insomnia. So that might be a reasonable option from that perspective. However, the response rate in most of the studies is much lower than the methylphenidate products. And there's also a delay in the onset of effect. So it takes about 2 to 4 weeks upon initiating atomoxetine to see an effect. So if we did that switch, our patient would be burdened with symptoms for several weeks while that drug hopefully took effect, but it may not be as efficacious for him as the methylphenidate was. So in this case, the methylphenidate patch offers a fair amount of flexibility in dosing. For example, patients who wear it for 9 hours a day get about 12 hours of effect. So we could have the patient apply it earlier in the day, take it off earlier in the evening, wear it for a shorter duration. So that again would allow the concentrations of methylphenidate at the end of the day to fall, so hopefully to reduce the insomnia that the patient's experiencing. There are a lot of other options. Keeping in mind this is a multiple choice exam, you have to pick the best option from what you're given. So it may not always be what you've seen in practice or what you've done in practice, but it might be the best option that you're given. So as I mentioned, clonidine can cause some sedation. Sometimes people will add a little dose of clonidine to help out. Sometimes they'll maybe do something like methylphenidate modified release, which doesn't have quite as long of a duration of effect, and then maybe give an immediate release dose in the early afternoon time, so that covers the home symptoms. So there's some different things that you can do, but you're kind of confined by a multiple choice exam, so you have to pick the best of what they have there. Okay? All right, so we have a couple of minutes left. If anybody has any questions now, or as Dr. Hemstreet mentioned, we'll all be waiting up here during the sessions and at the end if you prefer to come up and ask questions that way. Thank you. If you have questions, there are some microphones in the aisles if you want to step forward so that everybody can hear you. That'd be great.
Yeah. I have a question about how long are you generally concerned about the risk of kernicterus with ceftriaxone, and at what age can we actually start using ceftriaxone as an antibiotic choice?
So in general, with the drugs that you worry about with kernicterus, so ceftriaxone is one, sulfatrim, Bactrim is another. Typically, we say about 8 weeks of age. And then beyond that, we consider it safer. Any other questions for now? All right. Oh, somebody's coming. I see you. Don't run.
You discouraged the use of azithromycin in acute otitis media. In penicillin allergic patients, is there another choice?
In penicillin allergic patients?
Is there another choice outside of azithromycin in acute otitis media?
Well, then it comes down to, obviously assessing what their allergy is. Could you use a cephalosporin or not? You may use azithromycin, recognizing that it doesn't have great activity. Bactrim is another drug that we've used in the past. Again, the streptococcus susceptibility is not nearly what it used to be. So we start running into problems in that kind of patient population. Thank you.
All right, thank you, Dr. Oler. We'll go ahead and take a 10-minute break, and then we'll come back and we'll get going with the other end of the age spectrum.